Blood pressure is one of the most important parameters that needs to be recorded in a patient. Although the technique of measuring blood pressure is rather simple, the proper execution of the methods, especially when done manually, is important in order to get a proper recording. This forms the basis of today's video. This being the pilot video, I'll try to keep things rather simple so that learners of all experience levels can keep track. My name is Dr. Gokulasar. I'm the bloody physiologist. Welcome to my channel. So let's start with the first case. A 60-year-old obese man had been complaining of headache, giddiness and irritability for the past 2 months. He consulted a clinic and the medical assistant present there recorded his BP as 160 by 100 millimeters of mercury using auscultatory method. However, after further examination, the physician asked the assistant to recheck the blood pressure using palpatory and auscultatory methods, and the value recorded was 190 by 100 millimeters of mercury. Which is the correct BP value in this patient and why? What is the cause for this difference in recording? So this is a simple case scenario and many of you might have rightly guessed the answer here. The correct BP value in this scenario is actually the second one, which is 190 by 100 millimeters of mercury. This is because in the second instance, the blood pressure was checked using both palpatory and auscultatory methods. What is the cause for this difference in recording? Now, this difference in recording is due to a particular phenomenon which is known as the silent gap or auscultatory gap. This is what we are going to discuss today. So before we discuss about the auscultatory gap in detail, we need to understand about certain basic principles of blood pressure measurement. So blood pressure is usually measured using an instrument which is known as a sphygmomanometer. And one of the most important parts of the sphygmomanometer is the inflatable cuff. This cuff is placed around the arm and is inflated. Inflation of the cuff will cause a buildup of pressure that will compress the artery inside the arm upon the underlying bone. This will occlude its blood flow. So here we have actually wound the cuff around the arm. Inside the arm there is the brachial artery. So once the cuff is inflated by applying pressure, this will obstruct the brachial artery and the blood flow through that artery will be occluded. When exactly does this occlusion happen? That is another important thing that we need to understand. Now, occlusion of the artery happens when the outside pressure exceeds the inside pressure. So we know that artery is a vessel that carries blood. Inside the artery there is a pressure which is known as the blood pressure. Using the cuff, we are actually applying pressure from the outside as well. So whenever this outside pressure exceeds the inside pressure, the artery will be occluded. Now there is an important catch here. The inside pressure of the artery is not a constant value. It will oscillate between the systolic blood pressure and the diastolic blood pressure. The systolic blood pressure is the pressure transmitted into the artery by the force of the contracting heart. Every time the heart is contracting or when the heart is said to be in systole, it ejects a column of blood into the arterial tree, which will cause a momentary rise in pressure. This is termed as systolic blood pressure. Systolic blood pressure denotes the maximum pressure that can be attained inside the artery. The diastolic blood pressure is the pressure inside the artery when the heart is at rest. That is, the heart is in diastole. The diastolic blood pressure denotes the minimum pressure that is present inside the arteries. The extent of arterial occlusion depends upon the pressure difference between the outside and inside of the vessel. Let us try to understand this using 3 scenarios. The first scenario is where the cuff pressure is more than the systolic blood pressure. Now we know that the cuff pressure is the outside pressure and the systolic blood pressure is the maximum attainable pressure inside the artery. So when the outside pressure exceeds the maximum pressure inside the artery will be completely occluded. The second scenario is where the cuff pressure is less than the systolic blood pressure, but it is greater than the diastolic blood pressure. Now what happens here is, whenever the heart is relaxing, the pressure inside the arteries is the diastolic blood pressure. Because the cuff pressure is greater than diastolic blood pressure, the artery will remain closed or occluded during diastole. But every time the heart contracts, when the heart is in systole, there is an ejection of a blood column into the arterial tree and the resultant rise in pressure, leading to the development of systolic blood pressure. Now, because the cuff pressure is less than the systolic blood pressure, the artery will momentarily open up during systole. The third scenario is where the cuff pressure is less than the diastolic blood pressure. No points in guessing what is going to happen here, because when the outside pressure is less than even the minimum pressure inside the artery is going to remain open and the blood flow is going to continue as usual. This varying occlusion is a principle behind manual estimation of blood pressure. Based on this, we have two methods that are commonly used. One is known as the palpatory method. The other one is known as the auscultatory method. Let us try to understand how the palpatory method works. Here, the cuff is inflated over the arm, occluding the brachial artery. The radial pulse is simultaneously checked. As we know, the radial artery is a branch of the brachial artery. When the cuff pressure exceeds the systolic pressure, like we saw in the previous slide, the brachial artery gets completely occluded. Complete occlusion of the brachial artery makes the pulse disappear. The exact pressure at which the pulse disappears denotes the systolic blood pressure. Afterwards, when the cuff pressure is released, it falls below the systolic pressure, making the pulse reappear, thus confirming the reading. The palpatory method can thus be used only to measure the systolic blood pressure, but not the diastolic blood pressure. This is where the auscultatory method comes in. Coming to the auscultatory method, once we get an idea about the systolic blood pressure using the palpatory method, the cuff pressure is elevated some 20 to 30 millimeters above that value. And when releasing the cuff pressure, a stethoscope is used to listen to the blood vessel just distal to the area of occlusion. In this case, it would be the cubital fossa. This is where the scenarios that we discussed earlier comes into the picture. So initially, when we elevated the cuff pressure, it exceeded the systolic blood pressure. So when cuff pressure becomes greater than the systolic blood pressure, we know that there is complete occlusion of the brachial artery. So there is no flow of blood from the proximal to the distal part of the blood vessel. Now, as we reduce the cuff pressure further, it slowly dips below the systolic blood pressure, but it remains above the diastolic blood pressure. Now, what happens here? As we know, during diastole, the artery would remain closed because the cuff pressure is more than the diastolic blood pressure. But every time the heart contracts, there is a rise in the arterial pressure to systolic levels, and this will force open the occluded artery. So during diastole, again there is no blood flow, but during systole, there is a jet of blood that is rushing through this occlusion into the distal portion of the blood vessel wall. Now this jet of blood will actually be turbulent, and once they strike the arterial wall, this will result in formation of certain vibrations. These vibrations are actually audible through a stethoscope, and these sounds are known as Korotkoff sounds. It is the Korotkoff sounds that underlie the basic principle behind auscultatory method. The appearance of these sounds marks the systolic blood pressure, because we saw it first appeared when the cuff pressure just dipped below the systolic blood pressure. Now, as we reduce the cuff pressure further, this occlusion gradually widens out. So the artery was initially tightly occluded. As the cuff pressure goes down, the artery begins to open up further. So this actually changes the characteristic of the jet that escapes into the distal blood vessel. So initially this jet was very sharp, but then it gradually widens up. So because of a change in the character of this jet, the nature of turbulence also changes, and the sound that it makes while hitting the distal arterial wall also changes. This is the reason for various phases of Korotkoff sounds. When the cuff pressure falls below the diastolic blood pressure, the artery opens up completely. The turbulent flow that earlier existed due to the partial occlusion of the blood vessel is now replaced with a smooth laminar flow. So no more turbulence, no more hitting of the distal arterial wall, no more vibrations, and this results in the disappearance of Korotkoff sounds. Thus, the disappearance of Korotkoff sounds denotes the diastolic blood pressure. So we can say that the Korotkoff sounds appear at the systolic blood pressure and it disappear at the diastolic blood pressure. Now keep in mind that this normal pattern of appearance and disappearance only stands true for a normal pliable blood vessel. When the blood vessel is abnormal, especially in the case of thickening of vessel wall, this pattern can change. In such cases, the Korotkoff sounds appears, then disappears for a short while, only to reappear later. Now there are many theories surrounding the origin of auscultatory gap, but let us try to understand this from a mechanical perspective. The reason for the appearance of Korotkoff sounds was a turbulent setup inside the vessel and the resultant vessel wall vibrations. Now you can see the picture here. The vessel wall, once it started opening up partially when the cuff pressure went below the systolic blood pressure, there was the appearance of the Korotkoff sounds at the level of systolic blood pressure. And as the cuff pressure reduced, the artery slowly opened up more. There was still a turbulent blood flow which was set up. And finally, when the cuff pressure dipped below the diastolic blood pressure, the flow became completely smooth and laminar, leading to disappearance of the Korotkoff sounds at the diastolic blood pressure levels. So we can say that the Korotkoff sounds last between the systolic blood pressure and the diastolic blood pressure. So if they were to disappear, even for a moment, this could be because of a temporary disappearance of this turbulence. This disappearance of the Korotkoff sounds, termed as the auscultatory gap, occurs in stiffened arteries. So there has to be something peculiar with the stiffened arteries that will result in the occurrence of an auscultatory gap. Let us try to understand what that exactly is. Now this is because whereas in the case of a normal pliable blood vessel, the turbulence was maintained from the systolic till the diastolic blood pressure. In the case of a thickened artery, you can see that there occurs a phase when the turbulence is momentarily replaced by a laminar flow. Why does this occur? Now you can see that the story remains the same in a normal and a thickened artery. When the cuff pressure is above the systolic blood pressure, the artery gets completely occluded. Now what happens here? So in our case, the systolic blood pressure was 190 and the diastolic was 100. Once the cuff pressure was above 190, just like in the case of a normal artery, the artery was completely occluded. And what happens when the cuff pressure was reduced? Once it dipped just below 190, there was a partial opening up of the blood vessel, setting up of a turbulent flow, leading to vessel wall vibrations and onset of the Korotkoff sounds. But as you reduce the cuff pressure further, things starts getting a bit interesting. As the cuff pressure drops a couple dozen millimeters below the systolic pressure, a phase occurs when the artery is opened up, but the deformation of the arterial wall is not shaped adequately to cause a strong enough turbulent blood flow that can create vessel wall vibrations. This is because the thickened arterial wall is able to resist the pressure gradient that exists between the outside and inside of the vessel. The blood flow is predominantly laminar during this phase, leading to temporary disappearance of the Korotkoff sounds. As the cuff pressure falls further, the artery opens up further, and now the deformation is adequate enough so that turbulence is re-established. This will result in the reappearance of the Korotkoff sounds. Now as the cuff pressure drops further, it falls below the diastolic blood pressure, the artery opens up completely, the turbulent flow that was re-established now is replaced by laminar flow, and then the Korotkoff sounds finally disappear. Now you may ask, would this silent gap be present during palpatory method also? The answer is no, because once the cuff pressure is below the systolic pressure, the blood flow has resumed intermittently during systole. This means that the pulse has been restored in the radial artery irrespective of whether the flow is laminar or turbulent. Therefore, as soon as the cuff pressure falls below the systolic pressure, pulse will be palpable at the rest. This brings us to the very important question: what actually is the implication of auscultatory gap? Now, in order to answer this, let's have a quick glance at the case scenario. Now, the assistant initially checked the BP using only the auscultatory method, and the value that she got was 160 by 100. The true value was supposed to be 190 by 100. What went wrong there? Now, ideally, whenever we manually record blood pressure, we should always proceed with the palpatory method before doing the auscultatory method. This is so that we get an idea about the upper ceiling of that systolic blood pressure till where we have to take the cuff pressure. But when you directly proceed with the auscultatory method, we do not have such an idea. So whatever value that we set for taking the cuff pressure up to is purely arbitrary. And here what happened was, the assistant only did the auscultatory method. So when she increased the cuff pressure, she took it to the value which was dead in the center of the auscultatory gap. And from there, she reduced the cuff pressure and she got 160 as systolic. And she thought that this was the pressure at which the Korotkoff sounds appeared. But really, it was the pressure at which the Korotkoff sounds reappeared. And then it disappeared at 100. So this has led to a gross underestimation of the systolic BP, which is one of the implications of auscultatory gap. Yet another implication of the auscultatory gap is a gross overestimation of the diastolic BP. And you can actually imagine how this happens. Now imagine that the assistant actually took the cuff pressure till, let's say, 200 to 20 millimeters of mercury. And then from there, she reduced the cuff pressure. And upon reaching 190, there was Korotkoff sound. So this was marked as the systolic BP. And then on reducing it further by around, let's say, 170, the Korotkoff sounds disappeared. This could have been taken as a diastolic BP. But then this implication can actually be overcome by reducing the cuff pressure further. So if the assistant had reduced the cuff pressure from 170 back to 160, there would have been a reappearance of Korotkoff sounds. And in that case, she could have actually got an idea about the auscultatory gap. Now, although I mentioned about performing the palpatory method before doing the auscultatory method, we know that is not how things roll in reality. So if such a patient with a high BP comes to your OP, having this suspicion of an auscultatory gap can really prove to be advantageous. With that being said, we have come to the end of this video. I hope you enjoyed watching this content, and if you did, please like and share. Subscribe to my channel. Thank you and have a great day.